All right. Good afternoon, everyone. Today we will cover the content on the module number 6, which is hematologic system. The hematology includes all different types of anemias, the alterations that affect the blood cells or blood forming cells, which is like RBCs, red blood cells, white blood cells, like leukemia, different types of leukemias. We go over also the platelet alterations that affect the platelet count or platelet cells, like patients with thrombocytopenia or thrombocytopenia, which is the low platelet count. So the first slides talks about the composition of the blood, in which 7% will be proteins. The water content will be or account for 91%. And when we say protein, we say albumin, globulins, fibrinogen, prothrombin, and these are which will be responsible for what is called the oncotic pressure. If you recall this from the fluid electrolyte imbalance or fluid electrolyte chapter, we talk about the oncotic pressure, colloidal pressure. So here's the proteins, 70% of that, of the blood content. So which is, again, that's from the plasma. We said plasma is about 55%, and then the formed elements, 45%. It's like almost like half of plasma and half blood cells. And the blood forming elements, which is the blood cells, about half, 50%, almost 45%, which is platelets, the leukocytes, the erythrocytes, RBCs, white blood cells. Platelets account for 45%, almost like half, right, of the blood composition. And the other half of blood composition is plasma, in which that will include the proteins, water, and other soluble molecules, like ions, nutrients, waste products, gases, CO2, right, NO2, other substances that regulate fluids, electrolytes. So this is just a review, just a quick review of the composition of the blood, plasma, and blood cells, or formed elements. It's called formed elements, or the blood cells, which is white blood cells, RBCs, platelets. So the question here is, anyone can read it out loud, please? Volunteers?
Which are the most abundant cells of the blood responsible for tissue oxygenation? I want to say
Erythrocyte.
I'm sorry?
It's erythrocytes.
Erythrocytes.
Erythrocyte. Erythrocyte, which is it, what kind of blood cells is that? Erythrocytes.
Red blood cells.
Red blood cells. So the erythrocytes, which is the red blood cells, they are the most abundant cells of the blood, and they are primarily responsible for tissue oxygenation. The platelet, which is, can you mute who's, please? Make sure that you're muted, please, everyone. So the platelets, which is the thrombocytes, they are, we don't call them like true cells. They are not true cells, but disc-shaped cytoplasmic fragments, and they are essential for what's the function of the platelet?
Clotting, blood clots.
Right. So we need it for, they're essential for blood coagulation, which is in other words blood clotting, and contribute, or it will control bleeding. So it will prevent bleeding, and will aid or be part of the blood clotting or coagulation. So controls the presence of platelet counts between, what's the reference ranges, or like normal ranges of platelet counts, goes from 2, minimum and maximum.
So minimum is 150,000, maximum is 450,000, right?
Exactly. So there are some, very, differences, or like, I don't want to say like the inconsistencies or, discrepancies between, textbooks, but it goes from 140,000 up to 440, or you can see 150 up to 450. Either one is correct, but that's the average. Of the platelet count. The leukocytes, which is the white blood cells, the function of the white blood cells is leukocytes.
Infection.
Right. So it's kind of defense mechanism to defend the body against organisms, right? That can cause the infection. And also they are responsible for like the phagocytosis and remove the debris. If there is any insult, if there is any, trauma, and there is a, they can remove the debris from the affected area. And then we have the neutrophils. The neutrophils, they are the largest amount of the leukocytes. So the answer for this one, for oxygenation of the cells or the tissue oxygenation, is the RBCs, because as you see here from these figures, that it says that there are red blood cells, then the oxygen will, be from the lungs will be transported to, with that exchange of gases, then it will go to the bloodstream and it will bind to the RBCs. Then we have the hemoglobin molecules. Oxygen bound will bind or become bonded with hemoglobin molecules. And then that's going to be transported as blood move and circulate, right? And within and then between, cells and tissues, they are going to oxygenate the cells. So the anemia, when we say a patient is anemic, it's we have to identify what type of anemia is that. Is it iron deficiency anemia? Is it megaloblastic anemia? So we have too many forms or types of anemia. The anemia can be due to a deficiency in the number of the RBCs. Patient don't have enough RBCs, or it can be the quantity or quality of the hemoglobin, or it can be a combination, or what is called the osmolarity or the viscosity of the blood or the plasma, which is volume of packed RBCs, hematocrit. So hematocrit is determined by, or the value of hematocrit is always percentage, 50%, 45%, like that. And then the hemoglobin is always grams, right? Hemoglobin is 10 grams per DL, for example, this liter. 9.5 grams per DL. And then hematocrit is always percent. Now, causes of different types of anemia, it can be because our bone marrow is not producing enough RBCs, erythrocyte production. It's became like impaired, or there is a high rate of destruction of the RBCs. Red blood cells are being destroyed in a high, increased rate or speed of destruction is increasing, has increased to the point that there's more destruction more than the production by the bone marrow, or the blood loss. It can be acute versus chronic. When you say chronic, for example, give an example of chronic blood loss. It's like small, tiny amount every day being lost, like in the GI, for example, people with the upper and lower GI bleeding. Sometimes these the bleeding, it goes like unnoticed and concealed, or what is called occult. Did you cover that in Adult Health 1, which is called occult blood test? Fecal occult blood test. Fecal occult blood test.
No.
So when you say fecal means from feces, right? Occult means concealed, unnoticed. It's not, you can't see it with your naked eyes, right? And then obscured, it's not, unnoticed. You cannot notice, like it's not what is called gross hemat. When we say like in your urine too, in the urine, you say gross hematuria. Gross hematuria means you can see it's a bloody urine. Occult, you don't see, you can't see it. So fecal occult blood test, you test the feces or bowel movement for the presence of any occult blood. If we're like, something we can see, we don't call it occult, but occult because we can see it. So that's why we have to test it. There is some kits they can test on site, or you can send to the lab for testing. FOBT, fecal occult blood test, or the other name for it is called guaiac test. If you have heard it, or heard this, name, some nurses, they call it guaiac test. Guaiac test. So the cause is either there's an impaired RBC production or increased rate of the of the RBC destruction. It can be acute versus chronic. Acute can be like a hemorrhage. Well, during labor, for example, having a baby, the result in hemorrhage, placenta previa, or a motor vehicle accident or trauma, that is acute blood loss. Then, or it could be a combination of the above factors. Now, the classification of anemia, we classify it based on two things: the morphology. Let's just stick with the morphology, because morphology indicates about these two specific, factors, which is size and hemoglobin content. So we also can add another layer of the differentiation, which is the MCV, MCH, and MCHC. I'll just briefly go over these values. You will, as you review the hematology or the anemia profile, like the results from the lab, you will find these values. But the MCV and the MCH and MCHC, I will just briefly go over that. But the most important two elements of the differentiation, which is belong to the morphology, as you classify, is it normocytic versus a hypochromic, for example. Cytic always refer to the size of the RBC. Chromic to the color, which is the content of the hemoglobin. So hemoglobin content is being identified by the term called chromic, like hypochromic or normochromic. Normal hemoglobin content in the RBC, and then the hypochromic, we have less than normal hemoglobin in the RBC. The size of the RBC, is it within range? Is it distorted? Is it megaloplastic? So we have macrocytic, micro, or normocytic, which is the size. It determines or identify the size of the RBC. So these are the most important thing, things from this slide is just to understand when you say normocytic, microcytic or macrocytic. Macro is large, megaloplastic, for example. Normochromic versus hypochromic anemia. And we'll give examples for each type. When we say MCV, for example, I'm just going to briefly, I'm not going to into like a lot of details about the MCV and the MCH. When we say MCV, which is mean corpuscular volume, it is the mean cell volume, which measures the average of the RBCs, the average of the red blood cell volume that is reported as part of the standard CBC. Because when we do the CBC, which is complete blood count, we will identify, as we review the results, you need to know about the RBCs, red blood cells, you need to know about the platelet count, what is the leukocyte count, what white blood cells, all of these details. So under the MCV is just give you the, you can indicate. So it's, the MCV and MCH that are important because they can be used to differentially diagnose different types of anemia. But it's not within the scope of this patho class to go over these, these kind of advanced stuff. It's just to understand the MCV. When you hear that, or when you see this MCV on the lab, report, you will know that this MCV is just tells you something, or it's a measure of the average of red blood cell volume as part of the standard CBC. So that's just RBC volume. The MCH, which is mean corpuscular hemoglobin, so it's not the volume, it's about the mean corpuscular hemoglobin, is the calculation of the average amount of oxygen carrying hemoglobin. So it gives you something, or give you an average amount about the hemoglobin inside the RBCs. You can anticipate patients, like, for example, with macrocytic RBCs, to have a high MCH, for example. Patients with microcytic RBC to have a low MCH. So MCV, the volume of the RBCs, the MCH, the amount of the hemoglobin. So it's just, again, this is a little kind of advanced patho. I just don't need you briefly just to understand the difference between MCH and MCV. Now, EPO, this is I would say significant slide, very important piece of information, pertains to the anemia, because this explains very well why patients with renal problems, especially chronic, kidney disease, end-stage renal disease, patients are going for dialysis when they have renal failure, why they become anemic, severely anemic. Anyone can explain why patients with severe, with end-stage renal disease or with CKD, chronic kidney disease, they will become anemic? And you will still find this across the board. If you go to like dialysis center, hemodialysis center, all these patients going for hemodialysis because of the kidney failure, you'll find all of them across the board, they're all anemic. Any clue from, this is a patho class, this is where you start to understand the alterations of pathophysiological processes and disease process.
I think it has to do with the kidney not making enough EPO.
Right.
Right.
Yes. Remember this, the slide says the EPO, you can call it hormone, EPO, erythropoietin hormone. It's endogenous. It's the natural, intrinsic, endogenous, natural hormone produced by, it says here, primarily produced in the kidneys. And only just 10% in the liver. Which means in the absence of kidney function, patients who with end-stage renal disease, kidney failure, renal failure, they will have problem with this because the kidneys cannot produce the erythropoietin hormone. So what is the function of this hormone then? How patients with kidney problems end up with anemia? Because this hormone is responsible for the production. It will stimulate the bone marrow to produce the RBCs. And in the absence of this hormone, bone marrow is not going to be stimulated to produce RBCs. So patients with renal problems, they will end up with anemia because of that. The erythropoietin hormone also, it shortened the time to mature RBCs. Too much of this hormone is not good either, because patients with end-stage renal disease, they'll be receiving this as an exogenous synthetic epoietin hormone as a drug medication called Procrit, or these are like the brand names. Epogen, one of them, Procrit. These medications will be given to the patient with kidney failure or renal failure. So if I write it, would you be able to see if I write it down here, the names? Can you see? Yeah?
Yeah.
Yeah, Procrit or Epogen. Yeah, it's all of these are brand names for the EPO, erythropoietin. Patients will receive this either sub-Q or IV. It can be given either sub-Q or IV. But the patient will receive this and it's measured also in units. Patient will receive 5,000, 10,000, 15,000, 20,000 units. It depends, dosage, determined by, by the physician based on the anemia level and the severity of the renal failure too. So patient will receive this exogenously as in a medication, sub-Q or IV, and most of the patients, as long as they go for dialysis sessions 3 times a week for 4 hours each session, then they will receive this drug intravenously towards the end of the hemodialysis session. Otherwise, they will become severely anemic. So they will be on this drug to stimulate the bone marrow to produce RBCs, and they might be also receiving other medications like iron supplement and calcium and so forth. So the 3 mechanisms or alterations in erythropoiesis that will decrease the production of the RBCs. When we say erythropoiesis, means the process to produce red blood cells, or the mechanism to produce red blood cells. So the first alteration will be decreased hemoglobin synthesis, or there is a defective DNA synthesis in the red blood cells, or the diminished availability of the RBC precursors. Means that precursors means the ingredients, need precursors for the production of RBCs, and can be nutritional supplement or nutritional component. Red blood cells, like for example, when we say red meat or organ meats, or there are heavy, there is heavy presence of the iron. So the iron is a component to produce, just for production of the RBCs. So that cycle is clear now, that the kidney unable or failed kidney unable to produce EPO, it will not stimulate the bone marrow to produce enough RBCs, and then the patient will become anemic. So anemia in general, they will find that the patient with anemia, they would have a reduced oxygen carrying capacity because of the decreased RBCs. And they will eventually, because of the sequel of events from the, because there is a compensation, the symptoms, they're variable. We don't have all patients with anemia will have the same symptoms, but the compensation involves the cardiovascular, respiratory, and hematologic systems. So the initial compensation for the cellular loss is the movement of the interstitial fluid into the blood, which will cause an increase in plasma volume. And so the viscosity of the blood would decrease, so blood becomes thin. The thin blood is going to move faster. So the speed of movement of the blood and perfusion, or speed of perfusion or movement of the thin blood will be going faster. So it's going to result in what is called hyperdynamic circulatory state. Hyperdynamic circulatory state. And so the heart, or the cardiac dilatation, and the insufficiency of the heart would result if the anemia condition is not corrected. So we have to correct the anemia to prevent the heart from going into dilatation. And also, eventually patients from chronic anemia may end up with heart failure. We call this high output heart failure. So keep this in mind. Remember this when we go to the cardiovascular. When we cover the cardiovascular, we refer to the heart failure. We say high output heart failure. So I know that the mechanism is quite complex, but it's just to know that patients with anemia, they tend to develop what is called the hyperdynamic state, and that requires the heart to compensate by increasing the cardiac output. And if it stays longer, then that would result in failure, which means that we have to correct the anemia as fast as possible. So it has to be addressed, it has to be corrected, so we can prevent these by correcting the underlying anemia or condition, we can prevent this from happening, which is the high output heart failure. That specific name for heart failure, because we have left side heart failure, right side, right heart failure, and we have also what is called high output heart failure. Doesn't mean that the patient with anemia, they will consistently and continuously will be having the high output. They will have it an initial phase, and then the heart will fail. So initial phase will be increased contraction and increased cardiac output to compensate with the hyperdynamic state, and then eventually the heart will fail, cannot keep up with the same speed, with the same function. That's why this patients with chronic. So keep this in mind that this is very significant concept, which is chronic anemia can lead to hyperdynamic circulatory state, and then eventually patient can develop a high output heart failure. Manifestations from the tissue hypoxia. Patients will, from the increased rate and depth of respiration, they will have a shortness of breath. Heart rate. What do you think the heart rate will be like, going up or will be decreased? Like bradycardia versus tachycardia. So patients with anemia, would you anticipate them to have brady or tachycardia?
Tachycardia.
Right. So rapid pounding heartbeat that is expected. Again, because that's a compensation for the decreased tissue oxygenation or perfusion, which is tissue hypoxia. So the heart has to work harder and faster to compensate for for that tissue hypoxia. So it can supply tissues with more oxygen and more nutrients. The classic anemia symptoms, which is fatigue, dizziness, weakness, dyspnea, and pallor. Jaundice also is the cause of anemia in patients who had developed the anemia due to the hemolysis, because the destruction of the RBCs would result in the jaundice. And we will talk briefly about this process as well, why patients with hemolysis will become, be jaundiced or develop jaundice, which is from high bilirubin content in the plasma. Certain types of anemia could result in nervous system manifestations, like tingling sensations or numbness, weakness, and especially periphery weakness, like vitamin B12 deficiency, which is called pernicious anemia, or megaloblastic anemia, which is vitamin B12 deficiency. The low-grade fever would result from anemia, would result from the release of leukocytes, white blood cells. White blood cells produce what's called the pyrogenes from the ischemic tissues. So ischemic cells and tissues produce the leukocyte pyrogenes, and these pyrogenes will elevate the set point for the hypothalamus and will result in low-grade fever. So these are like major and most common manifestations of patients with anemia. Volunteers for this question. I want to take this question. Just for read aloud, and then require that you have to know the answer. No volunteers? Yes. Thank you. Go ahead.
Is large, so either it's C or D.
Can you read it aloud? Just read the question first, and then we'll go to the answer.
Who's
Chital.
reading?
Chital, can you just read the question?
Yeah, it's which of the following is a characteristic of the megaloblastic anemias? I would say C.
Okay, so we're talking here about the megaloplastic anemia. Remember I said like megaloplastic? Here, the cells, we refer to the stem cells. So the presence of macrocytes mean large cells. Megaloplastic means large cells. So the, the there are macrocytes that are usually large stem cells, which is megaloplasts in the bone marrow. And these cells are going to mature into macrocytes in the circulation. They're going to be produced as macrocytes, and then they'll be in the circulation. So these cells will have a large size, like increased in size, thickness, and volume. So deficiency in vitamin B12 or folate, folic acid or folate would result in this type of anemia. So always remember that megaloplastic anemia, macrocytes, large stem cells, and it's evident in patients with B12 deficiency, vitamin B12, or folate deficiency. Folic acid deficiency, vitamin B12 deficiency will result in this type of anemia, megaloplastic, what's called megaloplastic anemia. And so we'll take few different types of anemia. Like the first one is macrocytic normochromic anemia. So macrocytic normochromic is just the size is large, right? The amount of hemoglobin is fairly normal. So megaloplastic anemia. So one of them we said it's the due to the presence of megaloplasts, and one form of that is the B12 or folate, which is folic acid deficiency. And then we said that the hemoglobin content is normal because that's normocytic anemia. Normochromic. Normochromic means the content of the hemoglobin content, just hemoglobin content, is within range. So we have a lot of or too many defective mechanisms that will result in defective RBC DNA synthesis. So defective erythrocyte DNA synthesis can be caused by most, I would say the most common cause is the deficiency of B12 and folic acid, or it can be due to the defective RBC, which will die prematurely. So we know that the lifespan for the RBCs, the erythrocytes, is how many days? The lifespan for the red blood cells, the erythrocytes, is
120.
120 days, yes. So that's the lifespan for RBCs, 120 days. So defective erythrocytes die prematurely, less than 120 days. And we have other mechanisms, but the first two that are the most common mechanisms, the first two, or reasons. Now, when we say pernicious anemia, PA, which is usually result from the vitamin B12 deficiency, but the vitamin B12 requires what makes or accelerate or assist the vitamin B12 to be absorbed. Like vitamin B12 absorption needs what kind of factor? You need a specific factor. So in the absence of that factor, vitamin B12, if taken PO, is not going to be absorbed. It will result in no benefit if you take a PO and you in the absence of that factor. Which factor is that?
Intrinsic factor.
The intrinsic factor is significant for the absorption of the vitamin B12. So this is called pernicious anemia, which is the absence of intrinsic factor. And why would this intrinsic factor be absent? Either it's congenital, or there is a chronic disease, like adult onset gastric mucosal atrophy, like patients with chronic gastritis, for example, or patients who had experienced a gastrectomy, for example. Other factors like alcohol ingestion, like heavy alcoholism, hot tea. Even the hot tea sometimes could result in the chronic gastritis and then the intrinsic factor problem. Tobacco or cigarette smoking, and then, as I said, status post surgical removal or resection of the stomach, which is gastrectomy. These are examples of patients, because we know that the intrinsic factor is produced by the tissues in the stomach. So gastritis, gastrectomy, or other factors as mentioned earlier, all of these could result in the intrinsic factor deficiency and eventually the problem with the vitamin B12 absorption. So the manifestations, you will be looking at two main manifestations in addition to one, what you have listed in the slide. Two main ones: nerve demyelination, which is the nervous system like manifestations like a tingling sensation, numbness sensation, the weakness on the periphery, especially the fingers and toes, especially fingers, in addition to the beefy red tongue. The beefy red tongue would be in both pernicious anemia, vitamin B12 deficiency, as well as in iron deficiency, but you will see it more evident and more extreme in the PA, more than in iron deficiency anemia, which is the beefy red tongue manifestation. The other form of the macrocytic normochromic megaloblastic anemia is the folic acid deficiency anemia. And there is a link between the homocysteine and the CAD, or coronary artery disease. The folate is essential vitamin. We need it for RNA and DNA synthesis within the RBC. It's reducing the homocysteine level in the blood, because we have seen some type of association, recently between the homocysteine level, the elevated level of homocysteine, and the development of, or risk factor for the development of the coronary artery disease, CAD. So patients with high homocysteine level, they tend to have, or at high risk to develop the coronary artery disease, CAD. So this folic acid shown to decrease and reduce that level of homocysteine in the blood. This is kind of recent cutting edge, stuff and research, kind of, and evidence-based practice now about the homocysteine and the CAD. So folic acid reduced that, which would result in decreasing the risk factor for the CAD. The main source of folic acid will be from food, so dietary intake. Daily intake, we need at least like 50 up to 200 milligrams per day. It doesn't, so the folic acid is different than the vitamin B12, because B12 depends on the intrinsic factor. But this type, it doesn't have anything to do with the intrinsic factor. So it's not dependent on any other factors for the absorption. And after absorption, the folate will be stored in the liver. Patients who would be at risk for folic acid deficiency would be alcoholics, malnourished. And patients also here will have similar symptoms like pernicious anemia, patients with vitamin B12 deficiency in terms of the neurologic manifestations. They will have similar manifestations like the vitamin B12 deficiency, pernicious anemia, but except for that, neurologic manifestations will not be seen in the folic acid deficiency. They will have something called cheiloses, which is the scale and the fissuring of the mouth, and the scaly kind of cells or fissures in the mouth. Stomatitis, which is an inflammation and inflammatory process in the mouth, stomatitis, and the painful ulceration of the buccal mucosal tongue. The treatment, again, that should be treated with a supplement like folic acid supplement. And what is the other implication or clinical application for folic acid? Have you seen this like in other, maybe, you know, can talk from experience or general knowledge? Folic acid supplement, it can, in pregnant women, it can protect against what? Folic acid.
Birth defects.
Yes, neonatal congenital defects, yes, which is a neural, like spina bifida, for example. Spinal cord problems with the baby can prevent that. Microcytic hypochromic. So it's microcytic hypochromic anemia. Size decreased hemoglobin content, both. These type of anemias, we have an example of that would be the iron deficiency anemia, sideroblastic, and thalassemia. You will be probably have experience or able to maybe see iron deficiency, but not like, I'm not sure if you're going to see any of the thalassemia cases. Thalassemia as the type of anemia that affects, you know, children. So it's a familial congenital disease, have like genetic predisposition to develop this disease. It's more prevalent in the countries around the Mediterranean Sea. So any, you know, people from that descent, like, you know, from the Italy and the other countries around that, you know, Eastern, you know, countries, they may have that trait. And if both parents are carriers, they will, you know, that's recessive. So they will result in, you know, a baby with thalassemia. And it can be minor, it can be major thalassemia. But the patient with thalassemia depends on that minor or major. Major means patient is going to receive blood transfusion, it'll be severely anemic. And they will receive blood transfusion on, depends how frequent, but it could be like on a weekly basis or it could be like a monthly basis. So the microcytic hypochromic anemias, like iron deficiency anemia, who would be at risk for iron deficiency anemia?
African Americans.
No, I mean, not ethnic groups, about in general.
Vegetarians?
I'm sorry?
Would it be vegetarians?
Yes, vegetarians, yes. Yeah, I mean, ethnicity, it could be, yeah, it has to do with maybe poverty, like marginalized, you know, like, you know, communities, and yeah, and nutritional, you know, supplements or nutritional, I mean, intake. That can be discussed, that, you know, within that context. In addition to children
What
and
about pregnant women, Professor?
right, women of childbearing age. Right. So that's why we have to make sure that there is, you know, they are taking their, you know, iron supplement, folic acid supplement on time. So we call it, you know, like they have like, you know, a tablet that contains all these supplements in one tablet, combined with all these vitamins together in one tablet. So etiology, blood loss, you can see 2 to 4 mLs per day. And there are many causes of blood loss: surgery, hemorrhage, medications, cancer. Inadequate dietary intake. Out of the iron that we take, most of it is going to be stored, but 5 to 10% of the ingested iron is going to be absorbed. 5 up to 10% will be absorbed. Malabsorption could be a problem too. Etiology, like, you know, cause for the anemia, for this specific anemia, iron deficiency anemia, there is problem with the absorption of the iron, or the iron is being taken, but there is hemolysis. I mean, the RBCs, like, high rate of the hemolysis, then that could result in iron deficiency. And this is the most common type of anemia worldwide, not just in the US, worldwide. And most of the cases would be due to the nutritional iron deficiency. And the signs and symptoms will be similar to the megaloplastic vitamin B12 deficiency. Remember that we said, red beefy tongue. Here, it will be at a lower scale of red, sore, painful tongue too. So at some point, sometimes it's kind of challenging and difficult to differentiate between is that iron deficiency versus vitamin B12 deficiency until you, from the symptomatology, until you, review the blood, levels or blood, values and lab results. Chloronychia, which is the brittle, thin, stone-shaped nails, that could be also another manifestation of the iron deficiency anemia, like this. Pallor, also skin, like pale, pallor in the skin, paleness of the skin, due to decreased perfusion, decreased iron, and decreased hemoglobin too, because we have a problem with both. It's microcytic hypochromic anemia. The previous slide, this one, it's an important slide because it describes or provides an explanation about the process of the destruction of the RBC. How is the red blood cell, when it's being destroyed, it will disintegrate and result in releasing its content, iron, and then we have the heme, and then the bilirubin. And then the bilirubin is supposed to go to the stored in the liver, and then secreted with bile, and it will be present or released in the bowel movement. If there isn't an obstruction that will prevent or there's a high rate of RBC destruction, red blood cell destruction, a fast and high rate of that destruction, that the liver is unable to tolerate that rate of RBC destruction, then more of the bilirubin is going to be released in the urine and will be deposited under the skin, and it will be shown also revealed in the sclera. So what is called the jaundice? So jaundice will result from the increased rate of red blood cell destruction, and which exceeds the capacity of the liver of handling that high rate of bilirubin production. So the bilirubin is going to be, revealed and shown under the skin as jaundice, yellowish discoloration of the skin. The sclera too, the whitish, piece or area, on the eye, it will be yellowed too. And less of that bilirubin is going to be present in the stool, which will give the stool clay-colored or kind of whitish colored stool. And the urine will be more dark urine, kind of coffee ground or dark colored urine. So these are some manifestations of the high bilirubin, but most likely going to see the yellowish discoloration of the skin and the sclera. Sorry. Now the both normocytic, normochromic. So we have the cell size, the hemoglobin content of the RBC is within range. Normocytic, normochromic. this type of anemia, it is less common than the other types, the macro or microcytic anemias, less common than the other types. The 5 different types or subclassification of the normochromic, normocytic, or normocytic, normochromic. Aplastic anemia, one of them, post-hemorrhagic, hemolytic, sickle cell anemia, or anemia of chronic inflammation. Now, the aplastic cell, I'm not, going to, I'll just briefly go over each type, just briefly. Like the aplastic anemia, it can be congenital due to the chromosomal alterations, for example. We have something called pancytopenia. Pan, P-A-N, and then cytopenia. When you say pancytopenia, everything is very low. Decreased RBCs, decreased white blood cells, decreased platelet count, everything is significantly lower than normal. That's pancytopenia. That's what will be seen in patients with aplastic anemia, which is, you can from the word aplasia. So it's a red, pure red blood cell aplasia. And again, can be congenital or acquired. Acquired, like patients who usually are exposed to ionizing radiation, chemical agents would result from viral infections or bacterial infections. So that's aplastic anemia. Post-hemorrhagic anemia, this is post-hemorrhage, bleeding from the acute loss of vascular space, which is acute blood loss. Hemolytic anemias, we have a lot of examples that will go under the hemolytic anemia, hemolysis, which is the accelerated, which is fast destruction of the red blood cells. It could be an autoimmune hemolysis, antigen antibody reaction. It could also result from the hemolysis due to the drug, like a drug-induced hemolytic anemia. And then the last one, which is the anemia of chronic inflammation. And so the acquired hemolytic anemia. So I have also other like examples of the hemolytic. Let's just finish with this, with the acquired hemolytic anemia, because we said that the hemolytic anemia can be acquired or congenital. Because that's the most frequently seen, in terms of prevalence of the acquired hemolytic anemia. The extrinsic categories or factors can be physical factors, which include here like for example, patients who go to hemodialysis, the machine, the blood's going to be diverted, like you go into the artificial kidney, which is the machine, right, the filter, and then will return back to the patient's blood or vascular system. So this hemodialysis kind of mechanism and the machine and all of that kind of filtration process would result in a physical destruction of the RBCs too. So that kind of aids another factor why patients with end-stage renal disease, they're anemic, aside from the EPO erythropoietin problem. So intrinsic can be physical factors. It can be also immune reactions. We said it's like antigen antibody reaction that will destroy the RBC, or autoimmune reaction that will, the antibodies will attack the RBCs. infectious agents or infectious and toxins, which will foster the destruction or hemolysis in different ways. And there are like 4 mechanisms how the infectious agents can, and their toxins, resultant toxins, can result in hemolysis. The extrinsic factors, like for example, sickle cell anemia, and you will cover this in PEDS class. It's congenital autosomal recessive disorder, in which that the hemoglobin HbS produced, hemoglobin S, causes the RBC to become like elongated, different shape, elongated, stiff, and very easy to clump and result in blood clots and thromboses. And we have also the anemia of chronic inflammation. So when we say chronic inflammation, an example of that would be patient with end-stage disease. And it can be mild to moderate anemia. Patients with chronic liver disease. Patients with tumors or malignant, especially when it's malignant tumors, malignancy. Also you can get another example of what would be autoimmune disease, like for example, lupus, systemic lupus erythematosus, SLE, patients with AIDS, patients with rheumatoid arthritis. That's chronic inflammation, could result in anemia. So let's take this scenario and volunteers for this, please. More people to participate, because we had just read aloud the scenario, and we all as a group we can think about the answer. No more about the answer, just read it.
Henry is 77 years old and lives with his daughter and son-in-law. He has chronic renal failure, but likes to get out whenever he can to work in his daughter's backyard garden. Over the last few months, he began to go outside less often. He said he was feeling unusually tired and was running out of breath doing the simplest tasks. He also said his head ached and he often felt dizzy. His daughter took him to his doctor, who performed a complete physical examination and diagnosed Henry with anemia. 1, from what you know of Henry's history, what type of anemia do you suspect he has? Explain your answer and include a brief description of Henry's red blood cells, of how Henry's blood cells would appear on a peripheral blood smear.
Any clue from anyone? An explanation, an answer, given the discussions that we have in the previous slides? So a patient has a chronic renal failure, chronic disease, anemia. So why this patient is developing this anemia then? An answer? Chronic renal failure, anemia. What's the association between these two?
He's not making enough of erythropoietin erythropoietin. I don't know how to say it.
Yeah, EPO. You can just call it EPO. Erythropoietin, yeah, erythropoietin, which is EPO. Yeah, again, I spent like 10 minutes talking about the EPO, right? And the medication, patients with interstitial disease they take to recover and to fix the the anemia and have to treat the low hemoglobin level on the so the chronic renal failure causes this reduction in the
Of red blood
production
cells.
of the EPO first, the EPO, the hormone, to stimulate the bone marrow to produce the RBCs. So kidney failed, unable to produce EPO, which is responsible for stimulating the bone marrow to produce RBCs. That's the connection, that's the association. The increased levels of, so in addition to that, the increased serum levels of nitrogen and uremic toxins, they are because they would result from the failed kidneys. They cannot excrete these two waste products. So patient become uremic. High bun blood urea nitrogen, high creatinine. These are nitrogen and uremic toxins. They also, these two, because they are in large quantities because the kidneys fail to excrete them, their presence in the plasma, it will interfere with the erythropoietin activity. So if there is any erythropoietin, it will also be halted or be impeded or affected, adversely affected by the presence of these toxins. So we anticipate on the blood smear or the lab values or results that this patient would have a normal cytic, normal chromic anemia, because that's the anemia of the chronic inflammation due to the chronic disease, kidney disease. Number two, anyone wants to just read it out? Just read it.
Predict the cellular adaptations erythrocytes undergo when chronic. Oh wait,
Two.
describe the physiological basis that would explain why Henry's anemia would cause him to have the symptoms he is experiencing.
Anyone have any answer for this?
Because of the red blood cell is not producing enough.
Okay. So chronic disease anemia involve a decrease in what? In circulating red blood cells and oxygen carrying capacity of the blood, because reduced blood cells, RBCs, reduced, which means reduced oxygenation to the cells. So as a result, then the tissue hypoxia will result and create symptoms. When the cells are hypoxic, which is due to decreased RBCs, decreased oxygen carrying capacity for the RBCs, then these tissues, they are not getting enough oxygen. So that's why patient will be, will develop the weakness and fatigue and dyspnea. Okay, the third one, third question.
Predict the cellular adaptations erythrocytes undergo when chronic hypoxia is present. How would this be evident on an oxygen hemoglobin dissociation curve?
Yeah, I mean, this is a pure path EMP question. It might be a little, both EMP and slightly advanced kind of question. But there is an increased production, what is called the specific, product of what is called 2,3-D erythrocyte. But again, this is yeah. Don't worry about much about this question because this is a little advanced one. It's about EMP and how to apply the dissociation curve. There's this curve called dissociation affinity for hemoglobin affinity with oxygen, and then you have to apply that to the curve and you'll be able to answer the question. So let's move on to a different But that question, the third one, is that the result is that the oxygen is more rapidly released. The oxygen is more rapidly released by the RBCs in the areas where it is needed most. So the area that needs oxygen most, then that oxygen will be, again, this, this is a little bit, complicated, because you need to look at the oxygen hemoglobin dissociation curve to be able to, analyze and try to, answer the question. So let's go to the next one. Volunteers.
A nurse is caring for an 18-year-old woman in an outpatient clinic who was complaining of increasing fatigue for 3 months. She denies other signs or symptoms. She is generally healthy with no pertinent past medical history. She takes no medications daily. A CBC was ordered by the physician and the following results came back the next day. Should I read the results or?
Oh, no, don't have to. It's just we'll go over the question. The first one. Just read it. Just read it.
Okay.
You don't have to answer it.
Evaluate each of the above results. How does each result tell you about this patient's red blood cell function?
So this is like a classic scenario of the patient with anemia, and we're going to review these results because this is a good application of the results. And we have the reference values and ranges for each component, and the first one will be hemoglobin.
Hemoglobin.
So hemoglobin is low, right? So the
Yeah.
hemoglobin, hematocrit as well. So hematocrit is 30%. Both H and H, we call it H and H, hemoglobin, hematocrit. Both are low, below normal. So demonstrating the patient is anemic. And then to determine the type of anemia, you need to look at the MCV and MCH. I said, we're not going to look at this kind of advanced stuff, but at least you can tell from the MCV and the MCH also, you can determine the type of anemia from these two components. And in this case, both the MCV and the MCH, they are both low as well, showing that this patient is experiencing a microcytic hypochromic anemia. Because the MCV, it's the amount, it's the size, microcytic, MCH, the hemoglobin, chromic, so hypo, so both of them low, so microcytic hypochromic anemia. And this type of anemia is largely due to the iron deficiency, could be blood loss, could be thalassemia. So the iron deficiency is most common in children and young adults, as we know, right? So it's mostly going to affect the iron deficiency anemia. It's most common in the children and in young adults. The blood loss for young female that can be, due to the, heavy menstrual, cycle, blood loss, and can cause this one, young woman to experience the anemia due to that. So the 18 young old woman, that could be the last scenario, right? So the last scenario that has resulted in this anemia, which is due to the heavy menses or menstrual cycle. Second question.
What are the common signs and symptoms of anemia the nurse should monitor for in this patient? What is the physiological reason for each? Common signs and symptoms are like shortness of breath, dizziness. So
What
because
about, what about the heart rate? Palpitations, right?
Heart rate will be high.
Right, palpitations. And these symptoms are due to the tissue hypoxia. What about the skin? Or what do you anticipate to see about the skin to be?
So the skin will be yellowish and pale.
Not necessarily yellowish, unless the patient is, is jaundiced. with jaundice, with high bilirubin level. But in general, the decreased perfusion and decreased hemoglobin will result in a skin to be pale, yeah, from decreased hemoglobin.
Cold like hands and feet.
Yes. Yes. Number 3. Good. Excellent. Number 3.
What are the two most common causes of anemia in those aged female? Compare and contrast the pathophysiology of each.
So the two main etiologies in this age group, which she's 18 years old, the most common is iron deficiency, which occurs secondary to the loss of, we said, blood from the heavy menses or menstrual cycle, or from the decreased nutritional intake. So it could be, the cycle or the nutritional dietary, and that both are common in the adolescent age group. And either one, either decreased iron intake or the increased utilization of iron secondary to the blood loss will cause microcytic hypochromic anemia. And the other cause, which is not frequent, but it's can be also beta thalassemia or thalassemia disease, but it's not quite like common. But that could be another cause of this type of anemia. All right. Now, next is polycythemia. Polycythemia, which is the overproduction of the RBCs, which is all the way the opposite to the anemia, in which that this patient will have an increased rate of production, or there is a high level of hemoglobin. So it can be exogenous, it can be endogenous, or due to endogenous factors. So we have a high rate of RBC production, which eventually is going to result in high hemoglobin levels. And I'll give you an example of this scenario is that patients with COPD, chronic obstructive pulmonary disease, they tend to have an elevated hemoglobin levels, 20, 21, 22 grams per DL. And this increased level of hemoglobin in patients with chronic obstructive pulmonary disease, COPD, because they are constantly they live like constant, with constant struggle for their breath. They have a shortness breath all the time. So that attempt to breathe and to take the deep breath and to try to breathe normally is that will result in a compensation for the bone marrow to produce more of the RBCs. So this can be like compensatory mechanism in response to the constant and chronic hypoxia and chronic shortness of breath. So the polycythemia can be due to the exogenous medications, radiation, or endogenous due to the physiologic or compensatory mechanisms or immune reactions. So polycythemia can be absolute or secondary. Absolute, which is primary type, we call it, there's another name for that, it's PV, which is polycythemia vera. The absolute polycythemia, if untreated, the death in 18 months would result within that time frame from the blood clots or from hemorrhage, from thromboses or from hemorrhage. Secondary absolute type of polycythemia, which is an example, I provided with a COPD would be of that type, of the secondary absolute type. There's an increased erythropoietin, and the chronic hypoxia, which would result from example of that would be patients with the COPD, heart failure, people who live on high altitudes, like higher than 10,000 feet above the sea level. So it's all about the compensation for hypoxia and decreased oxygenation. So people who live high altitudes, higher than 10,000 feet above the sea level, they could develop the polycythemia vera, because as a compensation of the decreased oxygen, right? And then patients with chronic disease like COPD, especially like smokers with increased blood level of, with COPD or with heart failure. In addition to carcinoma, there are specific types of tumors that can result in erythropoietin, like what's called erythropoietin secreting tumors. Tumors that will secrete erythropoietin, EPO hormone. Let's see this question. Volunteers. I'll keep asking for people to read aloud. More? Yeah, go ahead.
53-year-old woman with diabetes notes that she has a general feeling of tiredness and a loss of appetite. For several months, while on her daily 2-mile walks, she has heard her heartbeat in her ears as a whooshing sound. Very knowledgeable about her disease and compliant with diet and medication, she waits until she sees her endocrinologist for her yearly examination. In the office, she explains her symptoms, and the physician collects a CBC in addition to normal diabetic laboratory tests. The results indicate an anemia, and she is referred to a hematologist. The hematologist reviews her laboratory findings and begins to explain her diagnosis of megaloblastic anemia. One further testing indicates that the woman suffers from a vitamin B12 deficiency, or PA. This condition is often associated with I want to say A, but I'm not sure.
Great guess.
Yeah.
What explanation?
The something with the intrinsic factor.
Perfect. Yes. Exactly. The principal disorder in the pernicious anemia, we said pernicious anemia, which is a vitamin B12 deficiency anemia in response to the absence of the intrinsic factors. The absence of the IF, the intrinsic factor, result in the malabsorption of the vitamin B12. It's like a transporter required for the absorption of the dietary B12. Environmental factors may cause chronic gastritis, or the condition could be also due to the autoimmune disease of the endocrine organs. But that's definitely, chronic gastritis is the correct answer. So the woman is treated with replacement cyanocobalamin, which is vitamin B12. When we say cyanocobalamin or copolamine, it's the same. Cyanocobalamin or copolamine, it's a medication equivalent to the vitamin B12. It's a B12 vitamin, synthetic. So this woman is treated with that B12 supplement over several weeks until deficiency is corrected. So monthly injections for the remainder of the woman's life are explained. Now, we have different formulations of this drug. We have tablets, we have injections, IM injections, like monthly injection for IM, for the vitamin B12. And patient acknowledge the importance of the treatment. Later on, like 1 year later, then the hematologist sees the woman for follow-up lab testing, and the woman again complains of fatigue. Part of the screening indicates that she has elevated serum iron and ferritin levels. So now the iron level and ferritin has increased. Confused, the hematologist reviews the medications, and she states that she has been taking several iron supplements. She's taking like this iron overdose. She's taking too much of iron, a multivitamin with iron daily after reading online. It's kind of, like teaching or education provided as the only sources from the online resources as as teaching tips about how to treat the anemia resulted in that she was taking too much of iron. So the physician again explains that the patient's initial diagnosis and informs the patient that she additionally suffers from secondary iron overload. So which means that the patient is solely relied on the online resources to treat her disease, and then eventually she developed an iron overload, taking too much iron. Now, the treatment for iron overload would be, so you want to get rid of the excess iron from the blood. Patients, before I get to the to the answer for this question, the hemosiderosis, which is excess iron buildup or the iron overload in patients who receive blood transfusions, frequent blood transfusions. Patients who receive frequent blood transfusions in the biweekly or monthly or frequent blood transfusion recipients with like thalassemia or with certain types of anemia, and they have to receive that on a frequent basis. The blood transfusion results in a high rate of RBC destruction, and they eventually have iron overload. The iron deposit in the cells and the tissues, and that could result in the dangerous kind of complications called hemosiderosis and hemochromatosis. So that iron, to prevent that iron from being deposited, and from that, to prevent that iron overload, the patient will be like, for these kind of, let's say the thalassemia, and patient is receiving frequent blood transfusions, they will have what is called the iron chelating agent. Chelating agents means the drug that is going to release the excessive iron from the blood. It will bind to the iron and will get rid of it with the bowel movement. Chelating agents like desferal, like an example of that would be medication to, get rid of the excess, iron excess from the plasma. That will be, and nowadays we have like a device or injector, subcutaneous. There will be, patient like a diabetic, like diabetes type 1, they will have an insulin, right? Insulin injector. They will have that insulin injector, sense the blood glucose, and it will inject the amount of insulin subcutaneously. Same thing, we have this one also. It can be, a device can be attached to a small tiny needle. It's going to be implanted, and it will also deliver the desferal in response to the dosage, in response to the amount of iron overload. So iron overload will result from the over destruction of the RBCs, or the excessive rate of destruction of the RBCs. Then the more iron will be like in large amounts, and will be in excessive amounts. So the treatment for iron overload, aside from that scenario that is described by the patients with chronic like thalassemia, receiving blood transfusions. This patient developed this iron overload because of the excessive ingestion of iron overdose. So the treatment would be
B.
phlebotomy. The treatment for overload is phlebotomy. Approximately 550 mLs of blood will be removed. 550 mLs will be removed with the phlebotomy technique, which is equivalent to about 200 up to 250 milligrams of iron. And this treatment will continue until the ferritin level falls into acceptable ranges.
Professor, that's what they do when your hemoglobin is too high also, because sometimes.
Yes, exactly. Same modality can be used for polycythemia as well. So individuals with iron overload, they should refrain from iron and what else? Which vitamin also? Which supplement? Vitamin supplement should be also refrained. They should not take in moderation.
B12?
Something had to do with the absorption of iron. What would accelerate the absorption of iron? Vitamin C. They should refrain from iron and vitamin C supplements. Aspirin can be used because aspirin has the anti-thrombotic features or properties in the treatment of polycythemia vera. Because patients with polycythemia vera, they have an elevated hemoglobin level, and one of the treatment would be to make sure the patient is hydrated, because we are going to dilute the plasma and blood, and that will result in less. We can decrease the risk factor for prothrombin or thrombus formation and blood clot. So anticoagulant, antithrombotic like aspirin would help too. Fluid intake, because the fluid should make the blood less viscous and more thin, so it will reduce the likelihood or the risk for blood clot to form. The plasmapheresis, just to know what is plasmapheresis as the modality here, is that it is the process in which that we will withdraw the whole blood is going to be diverted to a machine, and then we are going to remove the liquid portion of the plasma from the blood and then replacing that back. So which means that plasmapheresis, we can get rid of the antibodies, or if there is any antibodies, like for example, patients with certain diagnoses like GBS, then we will do the plasmapheresis because we can filter the blood from these antibodies. But just to know what is the plasmapheresis. The next question is, which of the following terms best describe E higher than normal white blood cell count? Higher than normal.
Leukocytosis.
Leukocytosis, yeah. Cytosis always means or refers to the increase. Penia refers to the decrease. Leukopenia, very low white blood cell counts. Leukocytosis, an increased level, blood cell count. Leukopenia, decrease. Leukocytosis, increase. So leukocytosis is an increase in the number of leukocyte or white blood cell count in the blood. And the decreased number of white blood cells is termed leukopenia. Same thing, you can apply the same prefix to cytosis versus penia to other white blood cells like granulocytes, granulocytosis, granulopenia, same thing, neutrophil, neutropenia, neutrocytosis, neutrophil. So we have, the prefix of the cytosis versus the penia. Cytosis means increase in number, and the penia decreased. So leukocytosis versus leukopenia. Leukocytosis, the normal protective physiologic response to physiologic stressors. And we have an example of that, like invasion of microorganisms. Your body is going to produce, a large number of white blood cells in response to the presence of microorganism. During the infection, that's one of the lab values you're going to anticipate to see white blood cells are going to elevate. And we have also other factors like the strenuous exercise, emotional change, temperature changes, patient who receive anesthesia, anesthetic agents, anesthesia, surgery, pregnancy, drugs, hormones, toxins. All of these are anticipated to increase the white blood cells. Pathologic conditions like in malignant tumors. There are some disorders called hematologic disorders, like due to the hematologic dysfunction. Now, leukopenia, which is a decline, decrease, reduction in white blood cell count. What's the danger of this? What is the significance or the complication that could result from the leukopenia?
Leukopenia.
Cindy and then Teo. That's fine.
Uh,
Cindy, go ahead.
I said you can get infected easily.
Okay, Teo. Thank you.
Yeah, I was gonna say the same thing. You're susceptible to infections.
Right. So a patient is going to be susceptible to infections with leukopenia, with low white blood cell count. And there is also, in the hospital, we have something called reverse isolation. And you can apply this when you go to the adult health 1 course, reverse isolation or reverse precautions or leukopenic precautions. Leukopenic precaution or isolation means you have to isolate the patient because of the significant decrease in white blood cell count, because patient should not be placed in a room with another patient. Should be in isolation because patient should be protected from others. This is the only isolation that patient is going to be protected from others to get infected from. Patient doesn't have an infection, but patient's low white blood cell count, it's not going to protect the patient from any infection or from any type of organism. That's why it should be in leukopenic precautions or leukopenic isolation, or another name for that would be reverse isolation. I mean, what could cause this leukopenia or decreased white blood cell count? Very prominent. You will see it all the time in patients with cancer and who are exposed or who take, go or receive the radiation therapy, or they receive the chemo and radiation or both. Autoimmune disease like lupus. And as I said, chemotherapeutic agents could result also in significant decline and decrease in white blood cell count. Okay, so I will stop here and we'll continue on Friday. So let me know if you have any question.